So today's topic for discussion is disturbances of eruption of teeth. So you know that deciduous teeth and permanent dentition both have different times of eruption. Okay, deciduous teeth normally they are seen from the time of 6 months when the child is born. After 6 months the mandibular central incisors start developing. So so it goes on like that. After deciduous teeth are shed, permanent teeth are replaced. So there is a broad range of variation between the eruption timings of the deciduous dentition and the permanent dentition. Even within the deciduous dentition, if we see, sometimes what happens is, you'll get to know that because of eruption timings may be different. So first we'll see premature eruption. So what are the disturbances in the eruption? We encountered premature eruption. Premature eruption may be seen in deciduous as well as in permanent dentition. Okay, premature eruption of deciduous dentition. What happens is when the infant is born, few infants at the time of birth they show presence of deciduous teeth. Deciduous teeth are present at the time of birth. They are called as the natal teeth. Okay, and neonatal teeth. Neonatal teeth are teeth which are usually seen in infants immediately after birth. Within 30 days of birth, if teeth develop, they are called as the neonatal teeth. So these are just premature eruption in cases of deciduous teeth. In cases of permanent teeth, suppose the deciduous incisor have shed early, deciduous teeth have shed early, the permanent teeth erupt early. So that is also a case of premature eruption in cases of permanent dentition. Okay. What is eruption sequestrum? Eruption sequestrum, it is actually a developmental anomaly, or it is a disturbance observed or encountered during the eruption of teeth. Actually, etiology of eruption sequestrum is when the time, what is eruption sequestrum? It is actually a bony spicule seen on the occlusal surface of molars. Okay, bony spicule seen on the occlusal surface of molar at the time of eruption. So why does it come? Why does the bony spicule is seen on the molar? What happens is during eruption of the molars, permanent mandibular molars, they tend to just accumulate the surrounding bone. During the eruption, the teeth will erupt through the bone, right? So they just accumulate some osseous fragment of the bone, and if suppose the bony spicule which the molar accumulates it's large, or the eruption of the teeth is a little bit faster, the bony spicule remains like that and it is seen on the cusps of oral mucosa as the teeth erupts in the oral cavity. Normally also, even if the spicule, molar takes up the spicule, by the time the teeth erupts into oral cavity, the osseous fragment should resorb. It will undergo resorption normally. If it doesn't undergo resorption, or if the bony spicule is large, or the teeth undergo early eruption, you can see the irregular spicule of bone. So eruption sequestrum is nothing but the bony irregular spicule. So it is most commonly associated, it is seen on the occlusal surface of molars, it is associated with molar eruption only, it is seen at the time of eruption of teeth only. The spicule is seen in the central occlusal fossa. As the tooth erupts into oral cavity, the spicule sequestrates and is lost to the mucosa. What are the problems associated? During the time of eruption of teeth, the child may complain of soreness in the area, or even before teeth erupt into oral cavity, when you are normally chewing or during your routine activities, you tend to feel slight discomfort in the area because of the presence of spicule. Okay, treatment for it, radiographically you can diagnose even before teeth erupt into oral cavity. Suppose the child is complaining of pain and you take a radiograph, you tend to see a opacity on the crown of the molar. Okay, you tend to see opacity. So it's you can just excise it for early eruption of teeth, like that. Another commonly encountered developmental disturbance is the delayed eruption of teeth. Delayed or retarded eruption, actually you can never say when the teeth is delayed, because the timings are different. Individuals, because of their dietary habits or because of their metabolism or because of endocrinal disturbances, some other cases, everybody have a different eruption timings. Okay, suppose the normal is suppose 6 to 8 months for central incisor, mandibular central incisor, but few child show, I mean, little bit variation in eruption also. So you can never tell when actually the teeth have shown retarded eruption or delayed eruption. But still, in some cases, delayed eruption like teeth are like broadly delayed. Eruption is delayed broadly. It is seen in cases of systemic conditions. Whenever you have calcium deficiency, extreme calcium deficiency, or rickets, or cretinism, all in syndromes like credocranial dysplasia and all, there is a delayed eruption of teeth is seen. These are the hereditary factors or syndrome associated factors. Other factors may be local factors like presence of fibrous gingiva, fibromatosis gingivae, dense fibrous connective tissue will be present. It hinders the eruption of even the normal eruption of teeth. So the deciduous teeth also may not be erupted sometimes. So local factors also hinder eruption of teeth. Or in cases of permanent dentition, also the same, the systemic conditions, presence of fibrous gingivae will hinder or because delayed eruption of teeth. So treatment is nothing but if you have encountered any calcium deficiency or endocrinal disturbance, correction of that underlying cause will automatically lead to eruption of these teeth. Suppose endocrinal disturbance is dead. Because of endocrinal disturbance, there is delayed eruption of teeth, right? So if you correct the endocrinal disturbance, automatically teeth will undergo eruption. Other developmental disturbance is multiple unerupted teeth. Multiple unerupted teeth is actually an uncommon condition. The teeth, the person affected may show presence of retained deciduous teeth, or the permanent teeth will not erupt. The deciduous teeth will fail to shed. There is the deciduous teeth remains in the oral cavity. So where is the place for a permanent teeth to erupt? Or sometimes even if the deciduous teeth have shed and there is space loss, there is space closure, it also prevents the eruption of permanent teeth. So the permanent teeth is present, but it's present into the bone, it's not into the oral cavity. Because of lack of space, it's just not erupting. Multiple unerupted teeth are also known as pseudoanodontia. The term pseudoanodontia is applied to it. The teeth may be present, but it's not coming into oral cavity because of some eruptive force, lack of eruptive force, as in cases of cretinism or rickets. So there is extreme calcium deficiency, there is lack of eruption of teeth. So other disturbance is embedded and impacted teeth. What are embedded teeth? Embedded teeth are teeth which are present inside the bone. They are prevented from eruption by some physical barrier. These are individual teeth which are prevented from eruption. Impacted teeth they are usually prevented from eruption by some physical barrier like bone. Okay. Actually, impacted teeth are teeth which completely lie within the bone. They are not into oral cavity. Okay, the teeth which lie completely within the bone are known as the impacted teeth. So, impacted teeth, most commonly impacted teeth are the maxillary and mandibular third molars. Mandibular third molars are the first teeth to show impaction. Like about 22% of mandibular incidence is about 22% of impactions, and 18% in maxillary third molars, and then the maxillary and mandibular cuspids, they show some 0.9% of impaction. So Winter gave a classification for impaction of teeth as mesioangular impaction, distoangular impaction, vertical impaction, and horizontal impaction. This classification is based on the presence of teeth in relation to the adjacent teeth. Okay, mesioangular impaction, the crown of the teeth will be mesially shifted because of the presence of the mesial teeth, it won't erupt. So the clinical picture is showing a horizontal impaction case. The tooth is completely into the bone, and we can see the ridge of the ramal bone. It's also completely encircling the crown of the teeth. And vertical impaction is nothing but the tooth is like, it's in the same normal position as other teeth, but the roots of second molar or the crown of second molar, it just occupies the space of the third molar. So there is no space actually for the teeth to erupt. Horizontal impaction cases are more difficult to treat actually. So they are all cases of impaction go for surgical corrections. Mostly impacted teeth are they are treated because of the problems they cause, like sometimes the teeth will be encircling nerve there, inferior alveolar nerve there, so you'll have pain which will be radiating to TMJ and all, or sometimes the cases of pericoronitis will be seen. So because of the problems they are extracted. Then impacted canines, maxillary cuspids, they also show, the canines which show impactions are also of two types. They may be mesioangular or again then vertical impactions. Vertical impaction is nothing but the canine, it's prevented from eruption. It is situated, the permanent canine is situated between the lateral incisor and the first premolar. There is no space to erupt for the canine. So that also go for surgical impactions, surgical corrections actually. So the next developmental disturbance of teeth is the ankylosed teeth. Ankylosis is usually seen in deciduous teeth. These are nothing but the submerged teeth. I'll tell you why they are called submerged teeth. Actually, ankylosis is most commonly seen in the deciduous second molar cases. The deciduous second molar undergo resorption sometimes. So when they undergo resorption, the root of the teeth, after undergoing resorption, it becomes blended with the surrounding bone. So they become ankylosed to the bone. Actually, the teeth undergoes resorption, but it becomes ankylosed to the bone. So after resorption, normally the tooth should show mobility, but here the ankylosed tooth, it becomes like stiff and hard and attached to the bone. Okay. It's called submerged teeth. Actually, ankylosis occurs because of trauma or infection or trauma or some sort of trauma to the deciduous teeth. Shall I start again?
From
periapical, I should start. Okay. Etiology of ankylosed or submerged teeth is trauma or infection. When trauma to the deciduous teeth leads to ankylosis of the teeth. Okay, diagnosis of ankylosed teeth is by radiographic examination. Even before radiographic examination, when you see the teeth clinically, the adjacent permanent teeth are at a greater occlusal height. The deciduous teeth normally have a lower level of plane of occlusion. The permanent teeth are much greater crown height, so they are little bit larger in appearance, and the deciduous second molar, whichever is retained or submerged, it will be like below the plane of occlusion. So clinically, these teeth, the crown of these teeth don't come up to the occlusion. So that is one way to diagnose. Or radiographically, you can diagnose that, you can clearly see that the deciduous, the roots have undergone resorption, the periodontal ligament space is lacking, and the roots appear apparently blended with the bone, and permanent teeth will be present below this submerged teeth. And clinically, upon normally when a tooth is percussed, you get a dull sound. But when in presence of when there is submerged teeth, when you percuss the teeth, you get a characteristic solid sound. Developmental disturbance of gingiva, fibromatosis gingiva, also known as elephantiasis gingiva or hereditary gingival fibromatosis. The name itself gives you an indication. Elephantiasis gingiva means the gingiva is enlarged to such an extent so that it got its name as elephantiasis gingiva. Hereditary gingival fibromatosis, the name itself gives that the etiology is hereditary. So actually, what is fibromatosis gingiva? The gingiva is enlarged to such an extent that you won't be able to see the normal teeth. When you open the oral cavity, the gingiva is full of fibrous and full of enlarged. Usually this condition, it is seen at the time of eruption of permanent dentition, at the time of eruption of teeth, either deciduous or permanent. This condition is seen in very young children. Okay, it is the etiology is hereditary idiopathic condition. Actually, it is idiopathic condition. The arches of both the maxillary and mandibular arches may show enlargement, and it affects both males and females equally. So the clinical appearance is one of dense, diffuse, smooth, nodular overgrowth of the gingival tissue. The tissue, if you see the enlarged tissue, there are no signs of inflammation. The gingival tissue is of normal color or little bit paler in color. So the tissue is enlarged to such an extent, the crowns of the teeth will be hidden. So you won't be able to see even the crowns. So the deciduous teeth fail to shed, the permanent teeth fail to erupt. So there are problems in delayed eruption also. When you see the histologic picture or the microscopically, the gingiva, The epithelium is thickened, it lacks retapex, it has dense fibrous connective tissue, bundles of collagen fibers are seen interspersed with bundles of fibroblasts. Treatment for this is gingivectomy or surgical excision of the fibrous gingiva. Sometimes if you extract the teeth present in the condition, if you extract the teeth, the fibrosis automatically regresses. Usually that is not indicated. If that suppose the teeth are deciduous, so yeah, you can extract the deciduous teeth so that the tissue almost regresses on its own. Some in cases of permanent teeth, surgical excision of gingiva may be carried out. Sometimes the condition is seen to be recurring. Another developmental disturbance is retrocuspid papilla. Actually, retrocuspid papilla is a normal anatomic structure. It is an elevated nodule seen on the lingual mucosa of behind the just mandibular cuspids. Okay, it is just an elevated nodule like a thing seen on mandibular lingual mucosa. Actually, clinical features are the retrocuspid papilla is usually seen in children at the ages of like 6 to 10 years of age. As age advances, as 18 to 20 years or 36 years, there is decrease in appearance of this nodule. So we can say that the retrocuspid papilla regresses as the individual matures. So it is nothing but a soft, well circumscribed sessile nodule located lingual to mandibular cuspid between the free gingival margin and mucosal junction. Nowadays, according to the authors, the retrocuspid papilla is not an anomaly, it's just a normal anatomic structure. When you see microscopic picture, the mucosa itself appears as an elevated structure. The presence of hyperorthokeratosis or hyperparakeratosis may be seen. The connective tissue will be highly vascularized and large stellate fibroblast may be seen. No specific treatment is required unless the nodule is of such a big size that it's interfering with your tongue or speech difficulties. So now we go to developmental disturbance of oral lymphoid tissue. So reactive lymphoid aggregate, lymphoid hamartoma, angiolymphoid hyperplasia with eosinophilia and lymphoepithelial cyst. So first the reactive lymphoid aggregate or lymphoid hyperplasia. Hyperplasia is nothing but increase in size of the cells, increase in number of cells. Okay. Reactive lymphoid aggregate. Normally the lymphoid aggregates, normal lymphoid aggregate, it is seen on the posterior dorsal portion of tongue. That is the pharyngeal mucosa, also known as the lingual tonsil. Frequently it becomes enlarged or inflamed. Usually in children you can see the presence of tonsils like that. It may be unilateral or bilateral. Most commonly it is bilateral. When unilateral, you can suspect a carcinoma like that. So this reactive lymphoid aggregate, if it is seen in oral mucosa, suppose as in buccal mucosa, it presents as a submucosal nodular mass. Usually after some times this nodular mass regresses because it is of lymphoid tissue, it will regress after some time. But if it doesn't regress, then you have to go for microscopic diagnosis to rule out, to differentiate from other neoplasms. A normal lymphoid aggregate is also known as the foliate papillitis. So this reactive lymphoid aggregate is also seen on other places like buccal mucosa, tongue, floor of the mouth. If it doesn't regress, then you have to go for microscopic diagnosis or biopsy and just rule out, differentiate with other lesions. Normally, because it is of lymphoid origin, it regresses after some time. Lymphoid hamartoma, it is also known as Castleman's tumor or giant benign lymphoma. It is also a form of lymphoid hyperplasia, okay, but giant benign lymphoma. In Castleman's tumor, what is Castleman's tumor? It is nothing but a benign cancellous outgrowth of lymphoid tissue. Normal lymphoid tissue is present throughout the body. Wherever the normal lymphoid tissue is present, there if benign outgrowths occur, they represent the Castleman's tumor. etiology of Castleman's tumor is nothing but increased production of interleukin 6. Interleukin 6 normally it is produced in the lymphoid tissue. It is just a normal thing, but increased production leads to this hyperplasia or hamartoma. This Castleman's tumor, it is of two types actually, hyaline vascular type and the plasma cell type. Most commonly Castleman's tumor is seen in the chest, stomach and neck. These are just the common places where the lymphoid tissue is present. Less commonly it is seen in the armpits and the pelvis. So hyaline vascular type of Castleman's tumor, they report cases about 90% of cases, and clinically they are asymptomatic. Just the normal lymphoid tissue, it's not at all painful, it's just asymptomatic in hyaline vascular type. Whereas in plasma cell type, the benign outgrowths, they are associated with systemic condition also. The presence of fever, rash, destruction of RBC, there is increased destruction of red blood cells or presence of anemia, and increased production of destruction of RBC and increased production of immune factors like globulins, that is the hypergamma-globulinemia is seen. Recently authors have proposed another type of this Castleman's tumor, that is the multicentric type. Multicentric type is nothing but here the individuals exhibit hypersplenomegaly, that is the enlargement of both the liver and spleen. Angiolymphoid hyperplasia with eosinophilia. Angiolymphoid hyperplasia with eosinophilia, it is also known as epithelioid hemangioma. It is actually an idiopathic condition. It presents as a groove, isolated or groove nodules or plaques, most commonly in the region of head and neck, particularly in the region of preauricular region. Okay. Angiolymphoid hyperplasia, it is actually characterized by increased proliferation of blood vessels, and along the blood vessels there is enlarged endothelial cells are seen. That is a characteristic feature here. So it actually presents as a benign tumor, or some authors have attributed it to be an unusual, just reactive process. The age is 20 to 50 years, age of onset is 20 to 50 years, and increased occurrence in males is seen. So clinically they appear as smooth surface dome shape nodules or papules. They are about 0.2 to 0.5 centimeter in diameter. They may be brown in color, or if they are erythematous they appear red, or they are crusted in color. Most commonly seen in the preauricular region, multiple or isolated. Characteristic feature how to diagnose this angiolymphoid hyperplasia is the histologic features. Here you see the proliferation of blood vessels. Along the blood vessel proliferation, the endothelial cell will be enlarged, giving a characteristic cobblestone appearance of the endothelial cells. And inside the endothelial cells, the nuclei will be ovoid nuclei, and there is intracytoplasmic vacuolation will be seen. The connective tissue shows infiltration with eosinophils. So the eosinophils comprise about 5 to 15% of the connective tissue. So that's why it is called as angiolymphoid hyperplasia along with eosinophilia. Next, the lymphoepithelial cyst. Lymphoepithelial cyst, it is actually seen in the normal benign lymphoid aggregate. Normal lymphoid aggregates are situated in the posterior portion of the tongue. The surface is encrypted, that is the surface usually the pseudocertified ciliated columnar epithelium. It shows presence of a crypt. The crypt has accumulation of orthokeratin. Okay, so if this lymphoid aggregate it has moved away from the epithelium, it develops into submucosal form, like it develops into a cyst like a thing. Clinically it is seen in most commonly the cases of oral lymphoepithelial cyst are encountered in the floor of the mouth. The commonest site for occurrence is the floor of the mouth. They present as movable, painless, submucosal nodule, sometimes with yellow discoloration. They may be translucent in appearance when seen in oral cavity under illumination. Okay, they are less than 0.6 centimeter in diameter. The cysts rupture as the lymphoid aggregates. The crypts are filled with orthokeratin. When the cysts rupture, they release all that thick keratinaceous material into the oral cavity, which is like foul tasting one. The age of onset is about third decade of life. So diagnosis is by histologic features. The epithelium is pseudostratified squamous epithelium, which is atrophic. Then it lacks reed apex, presence of orthokeratin and sometimes parakeratin. The orthokeratin, it's like sloughing away from the epithelial surface, and mucus filled goblet cells may be seen. Treatment for oral lymphoepithelial cyst is conservative surgical excision or enucleation of the cyst is carried out. Diagnosis of oral lymphoepithelial cyst is by histologic features only, and the cyst is actually seen in the normal lymphoid aggregate only, usually in the floor of the mouth. That's it. Now we go to the developmental disturbances of salivary glands. Aplasia is absence of the salivary gland. When you know that salivary gland is absent, usual symptoms may be xerostomia or dry mouth. When there is a excessive dry mouth, then you may suspect aplasia of the salivary glands. Then aplasia of salivary glands, usually it is seen associated with few syndromes like hemifacial microsomia, LADD LAT syndrome and Treacher's-Collins syndrome. It gives an impression that aplasia may be by birth, it may be congenital. Then xerostomia. Xerostomia is nothing but, it's not a disease actually. Xerostomia is a symptom of a disease. The excessive dryness of the mouth is nothing but xerostomia. So dry mouth, it may be because of a variety of reasons. Okay, presence of dry mouth is a normal finding in few individuals. Few individuals by birth they have a very reduced production of saliva, or at few times only you have reduced saliva. Like when you are taking some drugs like sympathomimetic drugs. Sympathomimetic drugs, they have a side effect of causing xerostomia. Then causes of xerostomia, nothing but psychological causes. Psychological causes is when the person is in cases of stress or anxiety, or when you might have noticed when the individual is during her examination time, the oral cavity you see reduced salivary production. So that may be the thing, or usage of anticholinergic or sympathomimetic drugs, or smoking is the cause of reduced salivation, or xerostomia may be associated with in presence of sialadenitis, inflammation of salivary glands, also there is a reduced production, or in presence of syndromes like Sjogren's syndrome. Xerostomia is one of the characteristic finding there. So what are the problems encountered because of xerostomia? Because of xerostomia, there is increased production or increased caries production in the oral cavity, and the mucosa and all the mucosa is not lubricated, so inflammation or erythema may be seen. Increased caries production, erythema. So because of all the difficulties, xerostomia can be treated by just giving artificial salivary substitutes, or like chewing gums, or frequent mouth rinses. Then next is hyperplasia of palatal glands. Hyperplasia is nothing but normally accessory salivary glands are present at the junction of hard and soft palate. If they are increased in size, they show hyperplasia. Usually seen at the junction of hard and soft palate. 0.1 to 0.2% prevalence is seen. Atresia is nothing but occlusion of the duct. Because of occlusion of the duct, atresia is nothing but occlusion of duct of major salivary gland. Aberrancy is the presence of normal salivary gland tissue in locations far away from the normal location, like Staphny bone defect. It is also a case of aberrancy. Next, developmental lingual mandibular salivary gland depression. Developmental lingual mandibular salivary gland depression, it is seen in the posterior region of mandible, also known as the static bone cyst or the Staphne bone cyst or the Staphne cyst or the Staphne defect. It is actually an unusual form of aberrant salivary gland tissue. Aberrant salivary gland tissue is nothing but the normal salivary gland tissue. It is seen in locations which is not normal. It is seen in locations which are far from normal. So the salivary gland tissue is here in case of Staphne cyst, it is located in the posterior lingual surface of body of mandible. It is a developmental defect. It is not a pathological defect, it is a developmental defect because the gland tissue, whatever the salivary gland tissue is seen, that is normal in all aspects. So the incidence of Staphne bone cyst is 0.1 to 0.3%. It is a developmental defect, not a pathologic defect. It is rarely seen in children. Here you can see in the clinical picture, if you see the right side of mandible shows presence of a ovoid radiolucency. So this ovoid radiolucency is nothing but the Staphne cyst or the Staphne bone defect. So if you can see clearly, the Staphne cyst is below inferior alveolar canal. Yeah, that has to be kept in mind. It is seen below the inferior alveolar canal and extending to the cortex of the mandible, inferior border of mandible. So the Staphne bone cyst, it has a predilection for males. It is a deep and a well circumscribed lesion. It is clinically, it cannot be made out. Actually, you cannot make out clinically because there is it is asymptomatic and there are no clinical presentation of swelling or such a thing. It is usually diagnosed incidentally or when you take a radiograph. Okay, radiograph shows a ovoid radiolucency located between the inferior alveolar canal and the inferior body of mandible. Treatment, no specific treatment is required unless and until there are cases of fracture in that area. Then the cyst has to be filled up. Differential diagnosis, you have to differentiate this Staphne bone cyst from another cyst called traumatic cyst. The traumatic bone cyst, it is seen above the inferior alveolar canal, but here the Staphne cyst is seen below the inferior alveolar canal. So that will be a differentiating point for us. Here it's a CT scan showing the Staphne cyst defect on the left side. Yeah, the arrow points to the defect. Left side of the mandible you can see. That's it. Thank you.